can be given subcutaneously up to twice a day, but these drugs are not orally administered. Okay. Now the low molecular weight heparins are kind of like that second generation group that I was talking about. They offer really better pharmacokinetic and pharmacodynamic properties. Okay, and the selectivity in terms of these drugs on heparin, I'm sorry, on thrombin and factor Xa is a little bit different. It's anywhere from 2 to 1 to 4 to 1 in terms of their ability to block thrombin to factor Xa. They completely inactivate Xa, but they only inactivate thrombin by 1/4 to 50%. Okay. And so those preparations include enoxaparin. You've probably heard of the brand name Lovenox, deltaparin under the brand name Fragmin. I've heard of tenazaparin. I've never heard of this brand name, and I've never heard of this brand name either. I think Lovenox is probably the more commonly encountered brand name low molecular weight heparin, at least on the Rush formulary. Okay, and so these low molecular weight heparins are structurally a little bit smaller, and this is probably the largest of the molecules that are low molecular weight heparins, and this is probably the smallest. But the concept is the same, and so here you've got your factor 10, factor Xa rather, and your antithrombin, and this molecule doesn't completely engulf the whole complex like heparins, like the unfractionated heparins did, but the concept is essentially the same. These two endogenous proteins want to bind, they have affinity for each other, and all this molecule does is it lowers the energy threshold, acting kind of like a catalyst, and facilitates the binding, so it increases the affinity. Okay, and so that same relationship exists here in terms of both factor Xa and antithrombin, and then this particular diagram doesn't have it, but the same also exists, although to much lower incidence, in terms of antithrombin binding to thrombin, which is factor 2A. Okay, so we'll use low molecular weight heparins during coronary artery, coronary artery balloon angioplasty during the stent placement procedure, and we're doing this to prevent thrombosis. Okay, there's relatively very little platelet effects. Okay, remember these platelets are intimately churning out thrombin, and here we see a much smaller effect on thrombin. We see a more beneficial effect. Most of the affinity in terms of these drugs is really kind of geared towards factor Xa, which is kind of the end of the cascade. I alluded to earlier that a lot of these low molecular weight heparins have kind of pharmacokinetic advantages. We can give them subcutaneously once or twice a day. This is in contrast to unfractionated heparin, which would be in an IV bag and then dripping essentially kind of continuously. And in terms of dosing, we can give fixed adjusted doses or weight adjusted dosages, and we don't have to really monitor coagulation. And we'll talk about patient monitoring a little bit later towards the end of this lecture. But understand that there are monitoring assays out there that essentially look at how strong the coagulation cascade is being inhibited with some of these drugs. Okay, I like this diagram. Let me move the slide over a little bit. I like this diagram because what it does is it essentially shows you the difference between heparins, low molecular weight heparins, and these synthetic heparins, fondaparinux, which is described here, and the molecular target. And so, heparin has the highest affinity to both factor 10 and factor 2. Low molecular weight heparin has a much greater affinity to factor 10 and moderate affinity to factor 2, but still present nonetheless. And fondaparinux is only associated with inhibition of factor Xa. Okay. Heparins have a complete antidote effect. Low molecular weight heparins have a partial antidote effect, and so that's again referring to protamine sulfate. Fondaparinux um, has no antidote effect. And the incidence of thrombocytopenia is the highest in heparins, which, again, these are the unfractionated heparins, and lowest in the low molecular weight heparins. All right, and so just to remember, factor 10 is important too. We've been talking about, the importance of molecularly inhibiting both factor 10 and factor 2. Fondaparinux, which, remember, recall only inhibits factor 10A, this is a viable pharmacologic target as well, because factor 10A is really kind of responsible for the conversion of prothrombin into thrombin. And by basically reducing the activity of factor 10A, you're basically kind of inhibiting the rate-dependent step in terms of thrombin activity. And so a good example of other factor 10A inhibitors include Rivaroxaban, also known as Xarelto. Okay, and so this is a little bit different than Fondaparinux. Fondaparinux is a heparin-like molecule. Okay, Rivaroxaban is a little bit of a different molecule. It's an actual chemical. It's not protein in nature. Excuse me. Right now, Rivaroxaban is indicated for atrial fibrillation as well as prophylaxis of DVTs after knee or hip replacements. Okay, so here's the dosing guidelines for prophylaxis for those orthopedic type surgeries, and then here's the dosing guideline for atrial fibrillation. So obviously this drug is going to be dependent upon creatinine clearance. Okay, and so obviously patients with really poor kidney function and atrial fibrillation could not use Xarelto or Rivaroxaban, and they'd be more inclined to use probably the some of the low molecular weight heparins that we talked about in the previous presentation. Lots of drug-drug interactions. There's a P-glycoprotein as well as a CYP3A4 known interaction. And then there's excuse me, there's some well-known drug-drug interactions that we'll go through and consolidate later on in this curriculum. Eliquis is another brand name for the Apixaban molecule, which is another inhibitor of factor 10A. Like some of the other factor 10A inhibitors, there's really no direct effect on the existing platelets. Okay, and this drug can be orally administered, which is convenient. And here we're using it for the reduction in stroke and systemic embolism in patients that have a non-valve atrial fibrillation. Okay, and we've also extended this to DVT prevention in terms of patients that have that are undergoing knee and/or hip replacement surgery. And so the next group of drugs are your direct inhibitors of thrombin. And so we said thrombin was such a key, essential player that we actually made a group of drugs that go after thrombin itself. Okay, and so the first group we'll talk about are, so these are drugs that directly interact with and inactivate free thrombin. So again, factor 2A, as well as thrombin that's already interacted with fibrin. So these are this is thrombin that's basically associated with a clot. Okay, and so at this point we're going to a site of active clot formation, and we're severely restricting the pro-clotting ability of thrombin. Okay, and so we'll directly and reversibly inhibit factor 2A, which is thrombin, at the active site. Okay, and there's a few drugs that are out there. They can be further subdivided into their chemistry based on where the binding site is. This is just background. I don't know if this is extremely clinically relevant, but it's interesting. The bivalent direct thrombin inhibitors bind to both the active site and another site called the exosite. And the main drug probably that you would more likely to be encounter clinically is bivalirudin. And so these drugs are actually derived from the medicinal leech. This is in contrast to the univalent, which just bind to the active site, and so these are your Gatrobans. So Argatroban, Dabigatroban. The older term, or the term that was used maybe just in the last 7 or 8 years, these drugs are called the novel oral anticoagulants, and so they're not really novel anymore. They're the newest, but they're not novel. They've been used in the clinic for quite some time. So dabigatran has really like the first oral direct thrombin inhibitor is on the market back in 2009, and it's and the reason we're talking about it here is that it got approval for atrial fibrillation that's not caused by any kind of valve malfunction. Okay, and again, the dosing guidelines are or suggest a renal elimination component. And there are some drug-drug interactions in terms of CYP enzyme systems as well as P-glycoprotein inhibition. Okay. Dabigatran, pharmacokinetics and dynamics. Remember we said it was orally administered. The bioavailability is quite small. It's only 3 to maybe 7%. The maximal plasma concentration is reached within 1 hour after administration. And the half-life, however, is anywhere from 12 to 17 hours, and so we see renal elimination of this drug. Argatroban, which is shown here, is a small molecule anticoagulant, and it's really used as kind of an alternative to patients that would use something like one of the Rudins for prophylaxis. And then we've also got a little bit of a subtype in terms of patients that are at risk of developing HIT or have a history of developing heparin-induced thrombocytopenia and are undergoing PCI. So it's kind of like sitting there on the shelf reserved for these kind of special cases. Okay. And the last group of drugs that are clinically significant